Sanibonani. Ninjain. Welcome, everyone. It's lovely to have you. I was going to say welcome to the sunny south coast of KZN, but we'll settle for the beautiful south coast, and I hope it warms up a bit, but the sea is always warm, guys, so get in the ocean if you get a chance. We chose this place, Bernard Gede and I, because of its proximity to the ocean. So I hope you have a lovely time the next few days. My name is Saul Cobbing. I'm the conference chair. I'm a physiotherapist who lectures at the University of KwaZulu-Natal in Durban. We are going to start. Does anyone want to volunteer? Yes, Mareka. So we're going to have our Rurisa chair, rural rehab.
Okay, so warm and wet welcome to everybody here. Thank you for coming to the conference. As usual, it seemed like more fun to run the wheelchair stand this morning than it did writing a speech. So I'm just going to read a little bit. But as Rural Rehab South Africa, if you don't know us, we have a website, go onto it. We are committed to advocating for high quality, affordable and accessible disability and rehab services throughout South Africa in rural and underserved areas. So disability and rehab are cross-cutting. They're cross-cutting across health programs. They're cross-cutting across services, across sectors, and across all spheres of life. Disability is everyone's business. Everyone's business. So whether you are in policy, whether you're in financing, whether you're a doctor, a social worker, a teacher, just a member of society, it is everyone's business. Okay. This month is International Spinal Cord Month. So this was fortuitous. And as usual, as you've heard, we are running our wheelchair obstacle course in the foyer. And we're using this obstacle course to advocate. We're using it to advocate, to open conversations about disability. Yes, this is just a physical disability slide, but it's interactive. So we're starting. We're trying to give you practical experience of what it's like to try and tackle a rural obstacle course in a wheelchair. And that is rural light. Okay, that is not what users face on a daily basis in rural and underserved areas, but also practical experience of the different models of chair. So you get the standard folding frame Tuffy, which is a bit of a plonker, but we still need it. And then you get, at the other end of the spectrum, the Rural Active WorldMade 3 Motivation Wheelchair. So I'm encouraging you to try all of them over the same obstacle course and make your own decisions on it. We're also encouraging each one of you to try this, and I'm serious. Even if you're not sporty or adventurous, we will make sure that you don't fall on your pip. Just come and give it a shot, okay? Jacques Lloyd over here will also be ferrying questions as an end user. We've got a particular drive to also highlight the sexual and reproductive health needs of people with disabilities and the complete lack of training, information, etc. out there to assist with this. And because disability is cross-cutting across all spheres of life, it's not limited to the medical model, it's not limited to healthcare. We are particularly excited to welcome the community health workers here and the mid-level rehab workers here this year. Could I have those that are here stand up? Mum, you. Please stand up. There we go. There's Mum you. Okay, so that's the first one. Everyone else? Surely there are more of you. Bangi. Put up your hand. There we go. Okay, Judith. Is she here yet? Some are en route. Okay. So these people are here to teach us as healthcare professionals, because we need to reorientate the way that we think. It's not working. So even if you are not a therapist, especially if you are not a therapist, we encourage you to go to these talks and to engage with discussions about disability rights and human rights. Okay. And with the current health reforms in the country and the new interest in engaging civil society and health professionals by the government, I think hearing the voice of professionals and end users is becoming ever more relevant now. And I would like to encourage you, because it is cross-cutting, everyone needs to be on board. We need your help. We need everybody's help in this fight. So please come chat to us at the stand, chat to us and experience the wheelchair obstacle course. Come chat to the mid-level workers. Come chat to the end users. Thank you.
Good morning, everyone. Wamgelegele to our Rural Health Conference 2019. Zuki sends her sincerest apologies for not being here, so that's why I'm speaking on her behalf. I'm currently the acting treasurer and social media manager for PACASA. So yeah, let's get to it. We want to take this opportunity to thank you and welcome you for all being here this year. It is always good to attend these conferences and catch up with colleagues. How we see everyone faring in the last year, and obviously what we've been up to since we were last here. We would also like to reaffirm our commitment to this conference, and we will continue to be part of making sure that it is successful. Colleagues, this year has been an incredibly difficult year for clinical associates. Many of us remain unemployed, all while we are here at our healthcare system that is unfortunately failing us. Not a week goes by where we do not hear about some sort of adverse event courtesy of our healthcare system. In the past few weeks, we have heard NHI is about to be launched, and we know that for a lot of healthcare providers, including clinical associates, it is creating a lot of concern. Earlier this year, there was a circular that went out stating that ClinAs should no longer be allowed to administer spinal anesthesia. Yet, the only reason we have become so good and indispensable at the skill is because we are always at our posts, ready to serve. In the past 5 years, despite our many efforts, the plight and roles of clinical associates in the healthcare team still remains unclear. When exactly will we be recognized as a valuable member of the healthcare team? Career pathing for clinical associates remains a problem. If we want to advance, we are forced out of our field of choice, preferably being a healthcare provider on the ground, into other things that may not necessarily directly positively impact our healthcare in our nation. Clinical associates, colleagues, we have the potential to be the backbone of the primary healthcare system. It is time that we all stand together and make this a reality. The MEC for Health in Gauteng has said that in order for healthcare to be delivered effectively and to be optimal, those that deliver it should work in a positive environment. Unfortunately, ClinAs don't work in a positive environment. The answer to being a good healthcare professional should not be to move to become a doctor. ClinAs also practice medicine, albeit at a primary healthcare level. We are properly trained to deliver primary healthcare and becoming recognized for our contribution in general surgery. And it is time that the healthcare fraternity stand with us and make our government understand at a district level, provincial level, and national level to acknowledge this. Our training is intense, but at the end of the training, we are capable of being valuable members of the team. Those of you who work primarily in rural areas are aware of the challenges with providing effective healthcare. Adding another cadre to the healthcare team should not be a threat, but rather this cater should be welcomed. Colleagues, we cannot do this alone. We need to stand together. This is not about one healthcare professional versus another, but is rather so that we can stand together and grow the community in order to have a healthy workforce. And obviously, this will positively impact our economy. We promote care, we should rather have preventative care than curative care. And we challenge you here today, doctors, nurses, physiotherapists, speech therapists, occupational therapists, community health workers, to come together and stand with us. Let us work as one. Acknowledge clinical associates as valuable members of the healthcare team. We want to be able to come to this conference every year and talk about the fact that we have become united. Let us not continue to talk about the same things. It has been over 10 years, colleagues. Surely we have proven our worth. We hope that you have a good conference, learn, reunite, and most of all, let us leave here with a renewed purpose to serve those who need us. Thank you.
I would like to welcome you all on behalf of RUNESA. Unfortunately, I'm not the chairperson, but I've borrowed the shoes of my manager, so with the hope that they will fit me. The reason why she gave me, she thought that they are going to fit me well. Okay, RUNESA, it's rural nursing in South Africa. It was started by a few members of nursing. When seeing that RUDASA have started their organization, so that as nurses we also have the voice that we can give to the community, as we are the important assets of the rural health. So this organization was started and its offices are in Cape Town. Since the chairperson is in Cape Town, the chairperson is Lawrence Gwen. Unfortunately, she's still coming. She has been delayed because of the rain. She's said we are having a website. We are a non-profitable organization. We don't pay anything to be this member, but we are the only voice that has been recognized by International Council of Nurses, so that the voice of the nurses in South Africa can be taken abroad. So I'm proud to be part of that team. Okay, as the rural health, we are acting on our voice with the hope that today all the presentations that we are going to give here or that are going to be given here are going to have our voices heard in the community. Thank you.
Hello, everyone. How are you? Good. Those speeches that were given, they're so hard to follow. I feel a lot of pressure, but I'm not going to try and compete. I am going to just take this moment to welcome all of you to the conference. It's very nice to see you all in KwaZulu-Natal. It already feels like such a long time ago when we met in Gauteng last year. But one of the things that I like about this conference is that there's always the familiar faces that kind of give you comfort. And some of these faces, you guys may not know, they've been here for many years. Every year they are back. And you're going to find out, I'm sure, over the 2 evenings that we're going to have, there's always a way of embarrassing a few people to make it obvious that they've been part of this community for a long time. But it is also that continuity that I find really powerful in this group. It's a small group of people who constantly engage slowly, and it's almost like it requires a lot of patience of identifying a problem and chipping away at it slowly over time. And a lot of us don't have that. And it is true that a lot of these people, as you will see already, they like to work in the background. The ones who are new to the conference, you are going to be put into positions of leadership immediately. You're going to be chairing this, you're going to be running that, as the chairperson has already said. But don't worry, they will always be there right behind you to support you. So don't be afraid when they ask you to do something. And as I say, you will see that every year they're here. So it's something that I find really powerful about this community. It is in many ways laid back, but at the same time it does so much. I can't even begin to explain to you how much the composition of the community has shifted over the years, tremendously. And I'm finding it difficult to even stand here and talk about Rudasa on its own, because it's almost like Rudasa in its sort of original form is disappearing whenever we are at these meetings. And but it's a good thing. It's a really good thing, because we know in reality we work as teams. But the past 3 days at UKZN, we came together. We're running a conference, a workshop for 2.5 days, to try and figure out how do we bring in a culture of training people together in interprofessional team, drawing from these notions of interprofessional education and collaborative practice, and bringing them together around the complex problems that require innovative tools to bring about change, like continuous quality improvement and so forth. And you think that it is simple. You will be amazed of the complexity and the challenge of it. But we take it for granted. And the question that I asked myself was, why are we only doing this now? We should have been doing this for a long time. And so I'm hoping that we can learn from the diverse culture of this community, but also the experience that the people in this room have. They have done this for many years. They have a lot of experience on the ground, and kind of figure out how to deal with the problems that we are faced with today. It's been a very difficult time in South Africa this week and the past couple of weeks. And we cannot ignore the challenges, the complex social problems that afflict our society. And they directly affect what we do every day. They affect who we are, how we represent ourselves. And so that's why for me, it's almost like all this sort of constructed boundaries that we have created are crumbling. It's like we need a different constitution to be able to successfully deal with the problems that we have. And it's a challenge to all of you and all of us to say, how do we position ourselves in the current situation, in the current environment, and in the near future, to be able to have the level of impact that our society needs. Not only what we can contribute, but what is needed as well. I want to embarrass someone. Where is Herman Reuter? Can you stand? It's impossible to embarrass him, right? No, keep standing. I just want people to see you. I met this gentleman in 2006. At the time, he was working for MSF. I'm not gonna disclose who you work for now because you've completely sold out. But there's something that's really powerful about bringing what you can do as a clinician and activism. And we don't celebrate people like Herman enough and for what they have contributed to this country. And for me, I'm starting to learn again that there shouldn't be a conflict between us doing clinical work or us doing research with the need to actually deal with the problems of the society. He taught me a lot in 2006. I was reminding him today, and some things are really simple, that sometimes you sit there, you're faced with a problem in front of you, and you think that's the end of the world. But he taught me to raise my head, and look around, and start acting and influencing the things that happen around you. But most importantly, teaming up with other people and getting comfortable in those teams. But this should not be complex. This should not be something that we should be talking about. It should be something that we are good at, and we are good at teaching other people. So, Chairperson, for me, I think today I'm finding it difficult to basically talk about Rudasa without actually recognizing the current situation that we are in as South Africans in today's world, and as professionals in terms of the role that we should be taking in that. But if anything, I know that this community right here has so much to offer to dealing with such problems, and I would like to spend this weekend reflecting a bit with people and kind of hearing what people think about what we ought to be doing. And we're being told that we're talking a lot, and we keep talking, and we kind of need to really be solving problems. And the rural community is good at that. What I know is that one thread that cuts across all of them is the creativity. They're good at overcoming challenges that they're faced with, and they're very resilient. And I'm hoping that we can learn together. So that's what Rudasa is to me. Thank you.
Thank you very much, Mosa. Absolutely true words. You see the last hashtag there is acting on our voice. So we can hear lots of voices here, but if we don't act on it, you could argue that it's wasted. Mosa's very modest. He hid his other hat, which is the Dean of Public Health and Nursing. We're very lucky at UKZN to have excellence like this. And unfortunately, Prof. Busi Mngama, who's also a nurse, she's our DVC for health. She couldn't make it, unfortunately, but she sends her regards, and UKZN put in some significant funding towards making this conference work. So in her absence, we are very grateful. Mosa's back. Prof. Moshabel, the Dean of Public Health.
Okay, I didn't see that coming. Yesterday, the headship of the university, the Vice Chancellor, the Deputy Vice Chancellor, Prof. Ngama from our college, all the deans of the different schools, we met with the not-so-new MEC of Health in KZN, Mama Nomagugu Smelani Zulu, who is a lawyer by profession and now MEC of Health. And the that was interesting to me. And of course, she had to explain to us why and how she ended up being the MSc of Health. But I'm not going to bore you with the detail of that. The one thing that was important from her is that she committed to working with the university to identify specific projects that need to be done in the province to solve problems. And she has got a few advisors that I think highly of, and I think that they are good guys. But I think that what we forget is that the job of an MEC is to listen to the people. And so yesterday when we were listening to her talk, is that she was taking these problems that come from people in the community and bringing them into the boardroom that we are sitting in and holding us to account for them. And I found that really interesting. And I know that on the one part, it's politics, it's publicity, it's about votes and other things. But on the other hand, you know, we cannot ignore the level of influence these people have. And I know that in previous meetings, you know, we get frustrated with politicians making a lot of long talks and all of that. But yesterday, we met someone who is basically now committed to meeting with us every 3 months as the university in order to make a follow-up on the specific tasks that we outline. And don't we need more of that? Don't we need to be able to set timelines? You know, yes, someone was telling me that we've got different learning styles. Some people are pragmatic, others are theorists, others are reflectors, others are something else. And when we were sitting in that room, someone was saying, okay, I will monitor the timelines on these specific things. I will bring in this person, I will do this. And this is high-level meeting of the department with the university. And so for me, I sat in that room and I felt like it's almost like we are doing project work, but at a different level. So I guess for me, the question is, for those of us who are here, is what is it that you would like the university role to be? What is it that you would like the leadership of government to be in terms of the problems that we face? And what kind of projects should be done and what timelines should be there? Because those timelines can actually be taken to the table. So when after we met yesterday, we all sat together and we said, this is the first time we've had a meeting of this nature. And I know that, you know, the first time you listen to this kind of conversation with an MEC, you think, where is this going to go? But our Deputy Vice-Chancellor said to us that 5 years ago, the relationship between the university and government was very poor. There was no engagement at all. But right now, the level of engagement that exists is incredible. So people build relationships. But those relationships can take a long time, but eventually they can lead to something that makes a difference. And so for me, I guess, as part of the university leadership, I felt that there is a wind of change in the way that we are engaging in the province of KZN. And I want to speak on behalf of the university and the College of Health Sciences to say that there is a genuine commitment currently to solving issues together with other people. And let's try and get on that train. And I know that our associations, I mean, I'm listening to Martine speak and I'm thinking she should have been in that room and sharing what she has to share, or someone should have been sharing what she wants to say on her behalf. But if we are going to speak to the converted amongst ourselves, which is great, but we need to be able to raise that to the level of the people that can do something about it. There's a real wind of change that we kind of have to hop on. So the University of KwaZulu-Natal also is going through the same thing. They've been talking to us about how the population, the nature of the population of the students has shifted a lot. We can no longer anymore start to pretend that issues of accommodation, issues of food are the concerns of the student only. A culture needs to change whereby we understand that for someone to be able to pass, they must eat. We cannot have a student who is smart enough to get admitted into university but does not have a place to stay. So all of these things now are coming onto the table that we never thought that they would. So I guess for me, I'm a little bit inspired by the way things are shifting. And I know if Prof. Ngama was here, she would also say to everyone that, you know, there is a moment right now to be able to put our hands together and do something. And for the few of you who are able to understand that and embrace that opportunity, take it on, try it. And if you are having struggles, let us know. There are people who are willing to hear you out. So let's see if, you know, we can work together as practitioners, as university and as government to try and solve the problems. I just don't see any other way going forward if we try and do these things on our own. But thank you, welcome to KwaZulu-Natal. And UKZN also is very happy to host all of you. Thank you. Bye.
Thank you very much, Saul. Good morning, colleagues, all protocol observed. As I've been introduced, my name is Ntokozo Mkhize. I'm the Director for Health Services in Ugu. You would know that KZN has 11 districts, so Ugu is one of those districts. I am really excited, having heard the partners and the chairperson doing the introductory remarks, and thank you very much for the warm welcome. I am not the MEC for Health, but I am going to do what I've been requested to do as a director of this district. Maybe before I go to the presentation, I think this says it all. Now you understand. You might be here at Carpenter Bay, close to the sea, but this reflects the ruralness of this district in terms of terrain, and I think you can see for yourself. I think this is too high for me. Okay. In terms of the map in Ugu, we've got 4 local municipalities. We also call them local sub-districts. Zumdoni, Mzwabantu, Umzumbe, Rainkonyeni, where we are. Now, this, because I've been asked to give a snapshot of profile of Ugu, this is saying we've got 85 wards in total. I'm not going to, this is the distribution per local municipality. Now, but I think this slide is the most interesting slide for me, to say amongst the 85 wards in this district, we have wards that are classified as mostly deprived wards. Out of the 169 in the whole of KZN, 21 of those are in this district. So what does this mean to us, especially linking to the theme of this conference? It means we still have wards that are mostly deprived, and ours is to make sure that at least these wards are prioritized in terms of health services. I must say, while I'm still here, that 9 of these wards, we have put our ward-based outreach teams. Now, we do have plans moving forward. It's only 9 out of 21 at the moment, but we've got short and long-term plans to ensure coverage to those wards. Now, this is the demography of the districts, 52% being females, and you can see the pyramid talks for itself. Suffice to say, in Ugu district, we've got 790,000 people, 154. 52% being females, and I must reinforce that in Ugu, 92.7% of the population is uninsured. Now, I'm not going to bore you with this, but it's just depicting the burden of disease. You would see the very first one being 8,175 in that particular period. that is STIs. Then you would then think, good, in terms of HIV and AIDS program, how are we faring? Now, in terms of health service delivery platform, please focus on the totals. High transmission areas, the sites that we serve per municipality, in total is 35 of those. Then we've got mobile services serviced by 16 teams going to various areas within the district. Then the actual points is 166. The health posts 4. And the provincial clinics, we've got 52. Then the community health centers, we've got 2. There's one in Kamalake and one in Mzumbe, which is 13 CHC. We've got 3 district hospitals. There is Murchison Hospital, G.J. Crooks Hospital, St. Andrew's Hospital in Mzwabantu. We have one regional hospital just a kilometer from here, which is Port Shepstone Regional Hospital. Now, I've touched on the ward-based outreach teams, and I do want to say this slide talks to the primary care re-engineering and preparedness for the the universal health coverage in terms of the NHI. We have 21 ward-based outreach teams. Then we have 18 school health teams. So you can see there's a long way to go. This is the distribution of those per the municipality. In terms of EMS, emergency medical services, we have 6 bases in Port Shepstone. Sorry, we've got 4 bases, 6 rostered ambulances that are based at Port Shepstone, 4 at Mzinto, 3 at Harding, and 2 at Mzumbe. And of course, there are challenges where you would understand that because of the terrains, it does affect the response time, especially for rural communities. Obviously, there's aging fleet and insufficient staffing. This slide talks to also the preparedness for NHI in that we do have what we are implementing CCMDD through space fast lane appointments, external pickup points, and adherence clubs and outreach groups. So our performance, you can see there, is reflected, but if you look at the very last row, it is saying, in terms of those clients that are on CCMDD, but specifically for registered for ART and they're active, it's that number, which is 41,000. Then percentage being 60%, but other chronic conditions is 23%, and there's the number 16,024. Then where we've got patients on ART and other chronic conditions like hypertension and diabetes, it's 12%. This slide responds to the President's call, wherein we want to have clinics where our own communities will own them and say, indeed, this is our clinic. Then we call those ideal clinics. So that picture is just a progressive report to say how many have reached platinum, gold, and silver per local municipality. I must say, we do have those clinics that we're still working on that have not achieved the status because of one reason or the other. This slide also talks to preparedness for NHI, wherein we have to register all patients, and we call this health patient registration system so that at least they have their unique identifier. And you can see if you look at the blue talks to the population per local municipality, and red is talking to the percentage that has been reached. In other words, as this district, we're doing well in terms of the preparedness for registering patients on HPRS. This, I've decided just to put one slide that talks to HIV cascades. And I'm comparing 2 quarters here, the April to June 18-19 for Ugu, compared with April to June 19-20. And you can see, in terms of these cascades, if you look at the extreme left, cascade the graphs that in terms of the first 90 of making sure that people are aware of their status, we're at 75%, and putting them on ART, we're at 99%, and making sure that at least the viral loads are done, we're at 85%. For those that we've done viral loads, to make sure that at least they are virally suppressed, and we are at 91. Can you give us a round of applause? We might have not reached the target, but this for us is actually saying, if you look at the dotted lines and the bars of those graphs, it's saying we are closer to closing that gap, and we really, really need the people on the ground, and we really want to appreciate them up front, their contributions to this. But we know that we still have a long way to go, and I must maybe hasten to say, Ugo and Umzunyati in the whole country, we have been chosen and called front runner district to say if we were to move at that pace from December or March 2020, there's a possibility of us achieving 90-90-90. Then for district achievements, very quickly, those who have seen the community survey for 2016, it showed that Department of Health in Ugo district scored highest score in the province, 58% for the level of satisfaction at hospital, and second highest, that is 53% for satisfaction at clinics. So to us, this is encouraging. We may say it's 58%, but we are at 58%, being the highest in the whole province. This is for the people, from the people on the ground. Then we also want to say we are in the process of implementing community-based primary care model, where we want to encourage preventive and promotive health, and making sure that at least we prioritized community-based services, not the actual facilities. We are grateful to our outreach team leaders and community health workers, and we do participate in OSS as part of stakeholder collaboration. And we do have PPP with the private hospitals within our districts. And we also are proud to say, in terms of the voices of the people, we do have what we call governance structures, clinic committees and hospital boards that have been trained and appointed by the MEC. We are in the process of making sure that they are getting stipend, at least for them going to the clinics or hospitals, to make sure that at least there's that oversight. We have, at a district level, appointed what we call a district health council. The district health council provide oversight at a district level. It's like a governing body from the Department of Education. Now, as I'm about to conclude, I do want to share the challenges. Briefly, challenges is to say we do have shortage of staff, specifically admin and therapists and allied staff. Of course, we do liaise and closely with our province. And we do have difficulty in attracting and retaining scarce skills categories of staff, especially in our remote rural areas like Umzwabantu, where there's Harding Hospital and other rural areas. We do every now and then implement retention strategies like accommodation and actually the career development opportunities. We are also, as Ugu, are experiencing increasing demand for new primary care facilities, of course, due to the burden of the disease. Hence, we advocate and we are implementing a model that is based at a community level, taking services to the people. Well, I want also to mention that we do have infrastructural limitations where, especially with the clinics that we name as ex-municipality clinics, where we have to prioritize the fact that infrastructurally there are challenges, but we're working closely with our head office infrastructure. Well, we have poor attention to care for clients on ART, where we implement the individualized case management and call center and automated SMS system with the support of our developmental partner, who is Broadridge. Then, in terms of teenage pregnancy, we have challenges We do implement She Conquers as part of multi-stakeholder approach. The last 3 slides talks to our future plans in terms of aspirations, and I'm not going to bore you. Our aspirations as Department of Health is to reduce maternal and mortality rates, is also to reduce neonatal mortality rates, to reduce child mortality rates, reduce HIV incidence and manage HIV prevalence. Then we have plans that talk to that, and improve TB outcomes, and also reduce mortality and morbidity due to non-communicable diseases. You know them better. Thank you very much.
Thank you very much, Ms. Mkhize. And I mean, that's really amazing. You're kind of seeing some of the challenges Ms. Mkhize spoke about at the end. And certainly if you drive inland, you'll see how very rural the terrain is, how difficult it is getting in there. I think you said something like 92% uninsured. But look at some of the great successes this district has had. So, you know, it's exactly what Mosa was saying. We need to speak to people like Ms. Mkhize, see how we can partner, you know, not always be filled with the doom and gloom. You know, we talk about the challenges. Let's find out how we can partner to really find some long-reaching solutions. Dr. Will Mapping from Vula is just going to come and talk about quite an exciting opportunity, I believe.
Hi there, my name is Will. As you can see from my shirt, my passion is improving rural healthcare. And if you want to buy the shirts, they're made by my wife, I'll sell them afterwards. But the real reason I'm here is that I run a company now called Vula Mobile. To give you a story, when I was at Madhweleni Hospital, I saw a patient with an eye condition and I didn't know what it was. So I gave him a letter and I said, please go to Mthatha. I couldn't get hold of the specialist on call. So I didn't see him again until 7 years later when I went back to volunteer as an ophthalmologist. And he came with the same letter. He'd had it for 7 years. And he had gone blind in that eye. And I realized then that we actually had the medication he needed the first time I'd seen him. I just didn't know as a junior doctor, but I did know as a specialist. So to help solve that problem, I had to get a little bit creative. As you know, all the rural health workers are the most creative ones. So I eventually managed to raise some money, and I built an app called Vula Mobile, and that connects rural health workers with specialists. It's now in 23 specialties, and as we speak, one patient is being helped every 3 minutes. However, I think that you guys will probably come up with the next best ideas. So what I've done is I bought some Dettol, because you're probably all using WhatsApp, but we need to clean that up and switch you all to Vula Mobile. There's also a competition because power was always a problem when I was at Madhweleni. So there's the smallest, most powerful power packs that you can put in your pocket to charge your phones. Also got some car chargers and some mousepad chargers for you to win. You just need to send an email to an email address. And then the big prize really is that in 2013, a company just had a go and they gave me 200,000 rands worth of design time. And that's what actually got Vula started. So we're going to run a competition for you. The email address is there. It'll send you a form and you can put down your idea. And then on Saturday, our chief technology officer, who used to run Takealot, he's worked for Google and Microsoft and many other companies, he's going to come and judge the top 10. And one of you will get a chance to have your idea built. So that's really exciting. I know it's technology, and I know technology can't solve all the problems, but perhaps we can make a small change. So thanks very much.
We are very, very fortunate to have as our first keynote, I suppose, representing Rurisa, the wonderful Bongi Zuma. She's going to come up. While she comes and sets up, I'm going to just tell you a little bit about her. From a personal note, I know Bongi is a senior advocacy officer at Create, an NGO based in Pietermaritzburg, but does work all over KZN and indeed the country, mainly around community-based rehabilitation. And I'm fortunate enough to be on the board of Create, so I see firsthand the amazing work Bongi and her team does. Bongi was trained as a community-based rehab facilitator, CRF, community rehab facilitator, in the 90s, Bongi? 96, 97. She's been at Create for over 20 years. If you come to some of the workshops, you'll see this kind of stuff spoken about, particularly with the community rehab workers. And in a lot of ways, it's an example how if we don't work together, things can go backwards. And we had these amazing people doing amazing work as community rehab facilitators, and essentially our rehab professions put a stop to that. There's a long history to it, but in 2006 that training stopped, and these people who were doing amazing work essentially either lost jobs or had to be sort of repurposed as OT technicians. So Bongi has kept fighting the good fight. She's gone all over the world. Recently she was in Finland, I know. This is quite daunting for her, Bongi. Am I allowed to say that? It's just amazing that she's agreed to do this, you know. Bongi is out there doing work, training people. She's someone who lives with a disability herself. She's a child a mother of a child with a disability. She's not so used to speaking at academic conferences. But Bongi, I hope already in the first hour you've realized this is a very friendly audience, people who they're very, very interested in hearing your voice and the voice of the people you're going to introduce. So, yeah, without any further ado, Bongi.
Sanbonan. Good morning. Goeiemorgen. Dumelang. Abazalwane naze nafuma kancane indawo. Ngivele ngiphenika nje. Ake sukumene kuyezwakala ku-presenter i-facilitator kuyezwakala. Can you all stand up? Those who can. So could you please greet your neighbor on your left? And also greet your neighbor on your right. And tell the neighbor on your right that ikshubile manje. What ikshubile manje? Thank you very much. Thank you, Sihlalo, for introducing me. I am very nervous, my goodness. But before I start my presentation, let us make a deal. Let us make a deal, okay? So please don't hate me after the presentation, okay? Because I know that there are teachers, there are nurses, there are doctors, right? Please don't hate me after the conference, okay? Deal? All right. So, and I don't know how to play this bioscope in this thing.
There we go.
Oh. Okay, so what I'm going to be talking about, I will talk about my journey as a person with a disability, being a mother of a child with a disability, challenges in my child's school, working with other parents of children with disabilities, breaking the news to parents about their children's disability. Bese sigcina lapha nje ekugcineni ngobuhle obenzekayo uma ngabe sesikwenze konke lokho. Kuyezwakala bazalwane. And I would like to say that I won't be able to stand for such a long time. So as you can see that I'm very tall and also have a disability. So I don't think I'll be able to stand for more than 10 minutes. What I would like you guys to do while I'm doing the presentation, right? Don't criticize my English, right? But I want you to listen the way the language disabled us as people with disabilities. And also how, especially the nurses, the way you use the language made us as parents of children with disabilities feel stupid, you know? and feel unwelcome in the hospital. And the fact that we are mothers of disabled, the fact that we are mothers of children with disabilities, it doesn't mean that we are stupid. Gezwakala. Whenever you are making those comments, when we are sitting with our children there and you are making all those comments, we can hear you. The fact that I have a child with a disability and you are making all those comments, I am not deaf. And please listen. It's because I want you to understand ukuthi language ni isikhubaza kanjani. Hallelujah. Hey, you can see that I'm a community worker, right? So I was born on a farm in Escort. The name of the farm was called Kwajebese. I was diagnosed with polio at the age of 2 years. I think I spent about 5 years in Gwahlangabatu Hospital. So what I remember was that I came back home, I think it was Thursday or so, because I remember my father going to town to buy a goat, then they slaughtered a goat on Friday to thank the ancestors that I was back. But because, the home was very far from the school, so I had to stay with my uncle. So you can see that, honestly, I don't know how it's like to stay with your parents. So it was from hospital, then those 2 days then from there, I went to stay with my uncle. So when I was discharged in KwaZulu-Natal, I had learned to get on and off the bed. I have learned basic ADLs, activities of daily living skills, and I was also toilet trained. But when I got home, there was no bed, and I had to sleep on the grass mat. And I struggled because I was not taught how to do that. There were no toilets, so I had to go to a bush. So I didn't know how to do that, so it was very difficult. So it was very difficult for me because, everyone at home, wanted me to go with them to the bushes, and I could see them squatting, and I didn't know how to squat, because I was using these calipers and I was using these crutches. So, I had learned to do that, to use the toilet, not to squat. So then I went my journey at the mainstream school. So I'm not going to talk a lot there because I don't want to run out of time. So then the challenges in the mainstream school, in the primary school, so they were kind of the same as the challenges at home. There were no toilets. So we were drinking water from the river. So you can see that, other learners were doing this, when they were drinking the water. So I couldn't do it. So I had to lie on the stomach in order to drink. But what was happening was that, when my uniform was wet, because I was trying to drink water, then when I go back to the classroom, the teacher will punish me. So, and, because I didn't know how to squat, Then when I was doing my number 2, and if I fell and dirty my uniform, I will be punished and embarrassed in front of other learners. And also, what other learners used to do is to take my crutches and put them there in the corner. Then when I wet myself, whoa, yay! So, wangishaya in such a way that wangikhumula, then ngasala ngepaint, wangishaya. Yebo anganandaba even nala makhaliphazi engiwagqokile. So but I was asking myself, but why? So but and the frustrating thing is that she was punishing me, but the children who put away my crutches, they were never punished. So it was really, really difficult. But anyway, because my mother wanted me to learn, so, I had to tolerate those teachers. So that was my journey in primary school. So may I have 5 volunteers? I want to show you in a role play. Where do I press the bioscope? So i-role play yami ithi zibonele wena wawungenze njani. Cela 5 volunteers. Woza ngaphambili. I am the teacher, right? I'm a maths teacher. So these are my learners. They were writing a test last week, so I'm going to be giving them the results of their test. Okay. Bashayeleni ihlombe because they are here. So this is Ntokozo. Naledi, Gugu, Zodwa, Zandile, and Mbongiwe Mlaba. Okay, so at least that one has got a surname, okay? So, I don't know how to, I'm not familiar with this surface, but the surface was if I fall, it will pick me up. So, Naledi, uzamile ngani yami this time, you know? From symbol H last term. So now uthole symbol E. Awuzamile mshayeleni izandla. Ntombazana, hayi kuyazameka from E to D shayeleni izandla. Kungconywana userious ngiyakubona wena, you know? Uma ngikubheka nje ngibona udokotela la kuwena. So uyabona ungaqhubeka usebenza. So the problem now, which you didn't read the instructions correctly. So, but in future, read the instruction correctly because I promise you, we are going to root ka symbol A. Well done. Shayeleni ihlombe elikhudlwana. Bengithe ubani wena igama lami? Bengithe uZandile. Zandile my girl. Sebenzile. And the standard sakho usiqhubeka sisibeke lapha. Well done. Very good. And here is a present for you. Shayeleni izandla, don't be jealous. Bongiwe Mlaba. 100%. No ways. Athi ngicheck kahle. Cishe ngenza iphutha. 100% kanjani? Umuntu onenyawo ebheke eceleni njengawe uthola kanjani 100%? Akazange check, akazange kopela ngizange nimbone. Akakopelanga. Ngeke mhlambe ngenza iphutha othi ngicheck futhi. Cha akukho ku wrong intanami. Kodwa umuntu owunyonga njengawe uthola kanjani 100%? Anilalela ke ntombi yami ngikutshele. Akuzukusiza ukuthola 100% kwakho because ama universities ababa accept cripples like you. So even if you can get those 100%, it's not going to help you. You can get your 100% from now to matric, but you will remain a government property. You will be nothing. So, and honestly, I don't know how you get that 100%. And you know what? Here's your exercise book. I'm not even going to give you my present. Okay? Because I don't understand why you're not letting 100% utolo. So, you are not going to get my present. That's it. Come on. So this is a true story. It happened to me. So so it happened to me. And what happened from that day, the learners started teasing me. The learners started bengibiza ngonyong, bengibiza ngawo wonke amagama because of that teacher. You know, what I would have liked her to do was to take her present, because the present, it was not bought by the school. She was just doing it, maybe those non-disabled learners. But you know, the fact that she threw the exercise book on me, and after that making all those comments, that really made me feel dirty. It made me feel nothing. And honestly, I felt like leaving school. But thank goodness that my mother was so supportive. And if it wasn't for my mother, honestly, I was not going to finish school. Because what my mother said, is that, when I go then I said, I said, go back to school and work hard. And if I have money, you will go to the university. But I really thank God for my mother's support, because that teacher actually wacekela impilo zabantu abaningi abakhubazekile, because most of those people, learners with physical disability in my class and other classes, because she was the only one that was teaching maths in the school. So they just couldn't make it, because they also didn't have support emakhaya. Okay, so that was my journey kuma mainstream school, both a primary nase high school. So what happened was that, unfortunately, I didn't have money to go to university. And that teacher's words really came to me and said, yeah, she was right, I'm nothing. Cripples like me won't be able to go to university. Because if when I got you were fair, why didn't my parents ungabanikeza imali for me to go to the university? So, but I just said, you know what? Let me do what I have, So we started a disabled people organization that fought for the rights of people with disabilities, raise our disability awareness, sends a sewing project, sends a t-shirt printing. So we're doing like different things. So because I was active in the community, I got an opportunity to be trained as a community rehabilitation facilitator in IUPAC in Ojobe. I was so excited. Said, yes, it's not a varsity, but it's something. So then after training, I got a job. Ngaleso sikhathi it was IUPAC. So it's Institute of Urban Primary Care, or CREATE now, in 1999. I was so excited. And, I was so excited because my father was no longer working. He had a disability, drove a tractor, and walimala wakhubazeka, so my mother was not working. That excitement, ukuthi ngibathengele igrosa for the first time, I don't have words to explain it. So, isn't it 1999? Sasihamba kahle. Siwolewele. Then, 1999, I was pregnant. I was worried that my mother and my father will be very angry. They were disappointed, but they were also happy, Like my mother was very cross, but my father said, Masithole, don't worry. At least ukhona umuntu uma sifa kusasa, ukhona umuntu ozokwazi ukuthi ambheke. Because the truth is, at the moment, abobhuti bakhe nabosisi bakhe babukeka ngathi bayamthanda, but we don't know what will happen when we die. So my father was very understanding. So ke ngalezo khathi ke, so remember ukuthi ungabe uqala ukuyoxukuza. Yini uxukuza ngesingisi vele? Antenatal. So then I had to start my antenatal clinic. So ngaye clinic, so a procedure was that you started the clinic, then after that you go to, I nearly mentioned the name of the hospital, then you go to the hospital. So in the hospital, so I had this card. I think, the nurses could see the colors of the cards and it made sense to them. And the nurse, staff nurse, ngisho unurse lo ogqoke into emaroon, angazi noma zazi u5 noma zazi ingaki. Ngizoxukuza sihlezi lonke sonke lana nakha kakusho. Wathi mbukeni umitheleni. Ungathi umthwalo kahulumeni wandisa omunye umthwalo umitheleni nje ngempela. Remember that in our culture, umuntu akamithi. Isilwane esimithayo. I don't know what is that in English. Kodwa umuntu akamithi. isilwane esimitha umuntu yakhulela. So obviously that nurse didn't see me as a human being, but wangibona njenge-object. And the fact that she was shouting, you know, and ephuma lana de sikhona amemeza abanye amanesi wozani nizokubona kumitha ngabe kumithela. Yo, Jesu. Then I just kept quiet. Then uma ngithoma sengifike eduze wakhe. Ngathi wesister. Kahle kahle uzama ukungitshela nje ukuthi lamaqhuzu agcwele ihlombe uqala ngqa ngama ukubona umuntu okhulelwe okhubazekile. Ngqa. Wasathi awenjalo umntakwethu. She's got such a big mouth. Ngibuza after lunch ukuthi kwenzakalani. Ngaqhubeka ngaxukuza ngoze ngoba ngiyabeletha ngo-December 27. So when I was 9 months pregnant, I organized a march. On the 3rd of December, it was International Day of Persons with Disabilities. I was still active. Zaziwa nje, for sure. Then, ngaba ne C-section ngoba but ngithi kwakusho udokotela wathi umntwana ngoba mkhulu then kwathiwa ngizohlinzwa. Umntwana wakhula kahle. Kwakukuhle nje konke kuhamba kahle and my parents were very happy. And muhle kanjani umntanami? So what happened was that when my son was 2 or 3 years old, I noticed that there was something wrong with him because he was hyperactive, misbehavior, engakwazi ukulala. Uyabona umntwana obusy ngaso sonke isikhathi uthi umkhuza la ulapha uthi umkhuza la ulapha. Ngathi no phela ngesikhathi ngise IUPHC kwakhulunywa ngendaba ye early intervention ukuthi kusemqoka ukuthi if you suspect something, there's something wrong with your child, hamba masishane eclinic. Then ngenza lokho ke ngakufunda futhi sasifundiswa usister lapha yana wayesenzisa i-primary health care module yakhona obizwa i-primary health care. Then ngafika eclinic. Wafika unurse, athi unurse awumntakwethu lana nesibhamu sakhe somfana. Athi lalela la mntakwethu. Don't waste our time. We are very busy. There is nothing wrong with your child. So ngicela ungasimoshela isikhathi, ngicela ubuyele ekhaya. Ungasibambezeli njengoba ubona nje ama patients engaka asadinga ukuthi onke ezilana. Ngisho ukuthi ke ongenani kuba amcheckeke noma I temperature noma yini. Wavela wambuka ngamehlo nje. Wathi ke angibuyele emuva. Wathi yakhwehlela wenzani ngathi akwenzi lokho ngathi wathi yini pho then ga explain wathi ayingasimoshela isikhathi. Then I accepted what she was saying, but deep down in my heart I knew there was something wrong. So then my son started a crash, then a crash nakhona babe ne problem ukuthi umntwana uya distractor unjanjani, then umntwana had to go grade R. Then got grade R, my son's teacher reported that my son was distracting other children, and she advised me to take him to the doctor. Then you said, you know, like, as much as I was like, yeah, I was happy that at least there is something wrong. Then I took my son to the doctor examined my child. You know, the doctors with Benzinjan. With their very good handwriting. Then so Kamisa, but the BP is fine, then they don't even tell you what fine isugu 100 over 3,000 yen. You know, BP is fine. Then back into your temperature, oh, it's fine. Okay. So then udokotela mesekwenzile konke lokho, then I write a letter and refer to the specialist. Then the specialist refer to another one, the other one refer to the other one, wamfaka izinto lezi khanda. Then ngasuka futhi akekho ngitshela ukuthi why am I going to this doctor, to that one, to that. You know, at least you know what engangakuthanda ukuthi ongenani udokotela ethi, I'm referring you to Dr. So because ngenza ukuthi nokuthi nokuthi, then ngabona ukuthi kunesidingo sokuthi, and whatever i-assessment osiyenzile, nginikeza ama-results because this is my child. Ukuthi nikhulume nodwa nje lesi singisi senu lana akungisizi mina as umama. So I was frustrated. So, but then kwakufanele ngikwenze ngizothini vele, angisiyo udokotela angisiyo nurse, so funa bangabe bethi jump ngithi how high. So ke finally I think emva kwale yini lokho kwakuthiwa i-scan or whatever, la babeka khona izinto la ekhanda. Then mangifika khona wafika futhi uyangena nje. So udokotela, so uphethe, I mean there's nothing wrong ngalokho, kuyezwa la. Then I said, oh, that means ama results sharp all is well. Then wafika wathi, oh mama, the results are back. Umntwana wakho une ADHD. Then I said, what is that? Honestly, what I remember was the first and the last word. It was attention and disorder. You know, when I had the disorder one, my goodness, I thought that my son was dying, you know. And when, you know, like, but why God, you know? And I thought, oh, is he going to die next week? You know, all those questions. And udokotela uyaqhubeka, and like uya explain, but it's like, ukhuluma you know, like iganyane elincane la medical. Uyabona at least like ngiyangacishe ngilingise ukuthi thini. But from there I should cool elingaka. Then I ended up not listening. Then I didn't listen. But honestly, you know, what was painful was that people, you know, they will think that because I have a disability, it would be easy to accept that my son had a disability. It was not easy. I was really angry. I was really angry with God because I was saying to myself, at home we are 10, I'm the only one with a disability. And now, a son with a disability, what is it, God? What is it that I have done wrong? So really, I was very emotional. And, you know, I knew as a CRF that I needed the counseling. But because of the attitude that I had in the hospital for the nurses, so with that nurse angithi ngibizela ukuthi umitheleni, obviously the social worker uzongibuza ukuthi uzaleleni. So I didn't go. So, and it didn't help me. So I was really angry, but thank God, isonto lami langisupporta kakhulu, especially upastor nonkosikazi wakhe, they really supported me. Challenges at my son's school. So, you know, personally, I wanted to go to school and actually give a feedback to the teacher ukuthi udokotela uthini. But because I didn't understand ukuthi udokotela uthini, I just put that letter from the doctor, ngayifaka lapho kwi-communication book, ngayinikeza uthisha. Then after 3 months, uthisha wangibiza, what asize sizodiscussa my son's progress. Then, because school policy BT, if you are going to see one of the teachers, you need to start at the principal's office. Then I wrote on the communication book that because the principal's office is on the 2nd floor, angizokwazi ukugibela ama-stepis, wasayina uprincipal, wasayina u-HOD, wasayina u-class teacher. Then mangifika ngaya straight eklasini. So ngithe ngiphakathi. Nakho uthisha kakwenza, ehamba lapha phezulu. What, look at this fat cripple in my school. Who do you think you are? Why didn't you start in my office? Honestly, I felt like running away because I did say in his sign. And fortunately, the HOD was teaching one of the classes. Then I said, oh, this is Deboho's mother. I said, oh, Deboho's mother. I said, no wonder the child has a problem. And, you know, like, it was so quiet. Then abantwana, they started looking around, othisha baphuma balunguza. And honestly, by the time ngifike ofisini likathisha, I was so angry. Empele ngangikhala because I was like, why kusho kanje kimi? But you know, engangikusho in my heart, because, you know, I was honest with the teacher that, you know, I'm not going to hear whatever you're saying, so I'm just going to go home now. So then I said, but the principal said, no wonder a child has a problem. I said, yeah, my child has a problem. And I don't know what the problem is. Then I said, no, weba ngiwesukuma and uthola ukuthi yini inkinga yomntwana. And I did. Then ngaya esibhedlela, ngafika ngikhuluma nonesi ngithi nurse today ngicela ungakhulumi nodokotela ukhuluma English because uzosho into engayi-understand. And unurse wathini? Wathi unurse wemntakwethu awuzuchoose ukuthi uzobona muphi udokotela. Noma umuphi udokotela oqedayo, you will see the doctor. Then I said, fine. Then waqala kudokotela ngibuza ukuthi kahle kahle yini ADHD and what happened, what causes it. Waqala wakhuluma those things, you know, wakhuluma ama-toxins, wakhuluma in. Then I said, but angibhema ngiphuzi in. Then ama-toxins ngiwathatha. Then I just waited for him to finish, and he finished. I said, when else ngithe ngisacela ukukhuluma nodokotela ukhuluma isiZulu. And I ended up demanding to have a isiZulu speaking doctor to explain to me what ADHD is. Then, to be honest, that doctor, before Dokotela ngibone, that is why I was saying, the fact that it's it doesn't mean that we are deaf, and it doesn't mean that we are stupid. So while I was waiting, you know, with your high heels, nama pantyhose, tumntagwethu hlezi ushoda ngomsebenzi ekhaya uhlele nje odokotela babhizi kabi ufuna nje udokotela ukuthi aphume lapha yana ezele yena ucabanga ukuthi uspecial. Then ngalinda ngoba kodwa ngathi mina udokotela ukhona kodwa udokotela usetiyeni ngathi okay uzobuya kodwa ukuthi uma isola ema wardini ngathi okay lunch time ngithi udokotela uzobuya kodwa udokotela ubhizi kabi ubhizi akanasi isikhathi. Then ngathi uzobuya yini? Kwathiwa yes uzobuya udokotela. But I don't mind waiting because I really needed the answers that day. So I think udokotela wazangibona like mind ungifike before 7, udokotela wazangibona after I think it was 2:30 or so. A very, very good doctor, Dr. Mbad, very good. And he explained to me very, very well. Akangasebenzisa leli amagama engawazi. And the way akasebenzisa khona language, you know, before asho konke lokho akusho, wathi imbangela, why isn't ilalele kahle language? Sorry for those who speak English. What imbangela ingaba yezinye zalezi engizazibalula. Kodwa kungenzeka futhi ukuthi umntana wakho ne-disability kodwa i-cause ayaziwa. Kodwa kusemqoka ukuthi umntana wakho umnakekele wenze nje and wangichazela kahle. And it was ukathatha about 5 to 8 minutes. Kuyezwakala. And what I've learned ngalolo suku was that sometimes ama-nurses, they tend to be a barrier between udokotela and the patient. So okwangisizake after saying understand, encourage her to learn more about my son's disability, and I made necessary changes at home. Because uma ngabe ibulala iplate or iglass, I'm feeling ngithukuthele kakhulu and shouting at him. Then I had to ask myself, Bongiwa, how are you going to stop shouting at your son? Then I said, okay, pheka izitsha lezi ezifayo. Then ngasebenzisa ama-tumblers. And I didn't want to make ama-tumblers kuba awakhe kuphela. So we all had to use ama-tumblers because I didn't want to discriminate my son. So also what I noticed was that when he was writing a homework, ngangina-curtains are floral. So yazi ngane ezine-ADHD zi-technical kanjani. Kuzothi makufanele ebhale and uyabona ukuthi akakwazi ukuyibhala lento. Then azosuka aye ekhethinini, this is green, this is yellow, and uyabona ngabathi no, lama curtains are distracting him. Then ngawasusa ngasebenzisa ama-curtain angana ma-flower. Then what I also needed to do was abangani bami, because when they were at home, they were like making these negative comments about my son. Then I said, you know, one day, so I invited them all to have tea. Then I said to them, we are all going to meet here, no more at home. because I wanted people who will come and visit me and support me, not people who are going to judge me, not people who are going to make negative comments about my son. At the end of the day, it's my son. As much as friendship here was important, but my son was very important. So then what happened was that, because, I'm based in Pietermaritzburg now, I just thought that, what, I struggled so much and I'm in the city. Then I was thinking, kubazali who are from rural areas. So part of the work that we do in CREATE is that we work with parents of children with disabilities because they have limited access to therapists, special schools, and psychologists. They live in communities where certain belief system influence attitude, practice, and practice towards children with disabilities. So for me, because yes, experience as a person with a disability and ngibonile experience as a mother of a disabled child, so it was important for me ukuthi ngingagcini ngihlezi ne-anger, but in order to deal with my anger, ukuthi ngishare nabanye abazali and together sibone ukuthi singakwazi ukuthi sisebenzisane kanjani ukuze sizolwela amalungelo ezingane zethu. Kuyezwakala? So ke i-approach yethu ke sisebenzisa sisebenza nabazali senza i-baseline to find out ama-experiences. Assume ukuthi because abazali baseMaritzburg baba nalezi inkinga, so masiye eKingcetshwayo or masiye eMkhanyakude inkinga zobe zifana, cha asikwenzi lokho. So we don't assume that they have the same challenges or resources. We use fabric mapping to determine this. So it's like something clear kahle. Kodwa laphayana igroup yabazali babantwana abakhubazekile. So indlela esibheka ngakhona i-mapping sibheka ukuthi imaphi ama-resources akhona emphakathini. So uma sikwenza lokho sikwenza in line with Convention on the Rights of Persons with Disabilities. So that abantu mangabe bethatha mhlambe is something on health njengoba ubona lapha sibabuza ukuthi iziphi ama-challenges ababhekene nawo kwa-health. So njengoba ubona-ke laphayana kubhale bona abazali. And it's a very interesting exercise because it encourages no mama or namahloni. So our challenges are common during fabric mapping. A negative attitude of health workers, lack of support of family members, traditional belief system of on disabilities and their causes, materials from hospitals, e.g. home programs that use cartoon diagrams. So, laba basebenza emakhaya nizo understand from mhlamba ama-CRFs, ama-community rehabilitation facilitators, nama-community health workers. Kuthina abantu, thina ama-Africa isikhathi esiningi, especially i-disability yonke nje. Ngaso sonke isikhathi once umuntu wane-disability, kuba nalento ukuthi kusho ukuthi umama has done something wrong to God or to the ancestors. So especially umntwana one-disability invisible. But they are so quick to judge. Which when a mama, you just need to tell the real surname. Or baza umntwana wakho nama demoni, nama evil ancestors and stuff like that. And see those beautiful home programs that you make. Those beautiful ones. Then you put them there. So omunye baba wathi kulo mama, njengoba ngizidlakela nje sendoda sengingaka. When uzama ungitshela ukuthi lengane yakho umithiswe lo mconjwana walendoda kuyazwakala, so akazange understand ukuthi just is a home program asisho ukuthi ingane yakhe injena, asisho ukuthi umama uchithe nomconjwana wendoda. Kuyazwakala, uyayibona into encane ovele wayithena around. Kuyazwakala ngenxa ukuthi ufuna ukwenza njani qali argument. So engifisa ukukushare ke namhlanje ukuthi how do you break the news to parents about their child disabilities. In giving the diagnosis, be specific. So don't say your child will have problems. When will these problems start? What must the parent do? Does the parent need to go to hospital? Which hospital? And may fika esibhedlela uzokhuluma nobani ngezwakala. Because I don't know whether the doctors are really scared just to tell you ukuthi hayi umntwana wakho disability blah 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 ngezwakala bese noma ngabe khula there will be problems ngizowabona ngani ngezwakala. Be specific, mususho ukuthi kucishe kufane negazi. Khuluma iqiniso, musungiduduza ngamanga ngivela ungitshela iqiniso ngezwakala. Lokho kuzokwazi ukuthi kungisiza. Use the parent's language. When giving the diagnosis, have a nurse that speaks the local language and that understand the correct disability terminology. In nurse understand any correct disability terminology. Ngezwakala. Isibonelo lapha ngithi some nurses when explaining the causes of CP baya confuse mind. Masebesho ngesiZulu mind no angithi mind ngesiZulu umqondo and ibrain ubuchopho kuyezwakala and mangabe setolikela udokotela uzobe sethi uthi udokotela umntwana wakhe ulimele umqondo angeke kwazi ukwenza lutho uzoba iqabisha ilokho ngempela kusuke kusho udokotela no akakushongo lokho udokotela kuyezwakala and honestly uma ungabheka futhi iqabisha ngithi mase libonile ulenze njani jijele ngadini. So lo mntwana uzobuna nini and uma sebonile because this is a human being umama uzomjikijela kubo kuyazwakala so yisho lokho kushiwo udokotela so then ngicabanga ukuthi into engalekelela ukuthi ama nurse abe familiar ne correct disability no terminology ukuthi angithi ngiyabona kuma clinical meetings mhlawumbe nime session eyodwa nje la enzobe nikhuluma khona ama correct terms kuyezwakala ukuze ngoba abantu ngesikhathi udedela lezi indaba kumina ngisuke ngikulalele ngepage eli-clean so whatever you are saying ngiyabhala kuyezwakala so kusemqoka ukuthi usebenzise inona i-terminology right and uqinisekise ukuthi ngiyenze ngifile ukuthi this is my child not ukuthi lento engiphethe is an object because uma ngabe uzosebenzisa izinto zokuthi kuzoba iqabishi nje obviously access umntwana loyo and angizukwazi ukumthanda because of indlela ochaze ngayo ngesikhathi udokotela ekhuluma. Invite power holders when breaking the news. Ama power holders ngaba omamezala o auntie o banibani uyabona lo muntu uma ngabe sekhulunywe emndeneni uma sekhulunywe umafungwa sewakancamalala akekho weqhayo ngezwakala noma sekukhuluma ugogo wala ekhaya akekho oweqhayo so invite low power holder. So don't give the diagnosis to the mother only, have the father or mother-in-law present. If the mother is not married, get the sister, mother, aunt or anyone that she thinks will support her on the journey. When people ask questions, the power holder can help to answer the question. If not, the mother is accused of having done something wrong to God or ancestors. Uyabona ngalesikhathi remember that nakumina when dokotela esho ukuthi umntwana une ADHD igama engalikhumbula attention no disorder emva kwalokho there were those floods of questions in my mind so have umuntu ozoba khona lapho ngoba ekugcineni you know if you can have that bazalwane yazi khona iqiniso elingalazi iqiniso elinganjani elingalazi uyazi uma ngabe silala thina bomama bengane ekhubazekile our bedrooms are courtrooms because injalo udinga ukuanswera something kumamezala udinga ukuanswera something kumyeni wakho udinga ukuanswera something kuma family members so if singakwazi ukuthi sibabize labantu ngesikhathi kunikeza i-diagnosis at least kunomuntu ozobe ekusupporta kwi-family ngesikhathi sebekuhlasela bonke ukuthi khuluma iqiniso wenzeni namfazi la ekhaya ngezwakala so biza umuntu ukuze ezokwazi ukuthi no ngiyakhumbula ukuthi udokotela utheni and isibonele esinye nje ukuthi uzothola ukuthi udokotela umntwana ube ne-CP ngenxa yokulekha kwe-oxygen and ubaba uzomthola ukuthi uthini athi hey umoya kaNkuluNkulu ubukhona mfazi ubukhona awukazi uphela so ke ubuyephi lo moya umoya kaNkuluNkulu nje angeke ungitshele ukuthi nge-oxygen nje ingane izavela igoqana ibe nje umoya kaNkuluNkulu ube ukhona and umoya kaNkuluNkulu ukhona yezwakala then let's find another way, you know. Ngizosiza nina base university ngoba ngithi ngikhuluma nesilungu esi-right. Ake sifine elinye igama esingakwazi ukuthi senze ama-family members ukuthi understand ukuthi uma ngabe sithi kube ne-lack of oxygen yini le ngoba uqinisile ubaba uyamphukisa yini umoya kaNkulunkulu ukhona uma uphumelela phandle umoya kaNkulunkulu ukhona kuyezwakala but asifinde enye indlela that will make sense kubantu lapha ya at a community level. So kusemqoka ukuthi ke sibe nama referral chain, give the mother contact details, people that she can talk to for support, mhlambe social worker. And honestly, before you refer umama kulelo social worker, kuyezwakala bazalwane. Mhlambe kuyezwakala suggestion yami ezibongiwe. Lelo social worker mhlambe mseni lapha therapy department ukuze ezoba ne background of background and different understanding of different types of disabilities, because from our experience as parents uma ngabe uyafika ngifika noTebogo ngizele for counseling then social worker izombheka nje uTebogo kabili kathathu it's no, there is nothing wrong with your son webongiwe, inkinga yakho nje you've got poor parenting skills. Because yin abai understand into ADHD abai understand into autism. So before refer mama ngithi umama ngabo mosala phana udinga ukuthi ayohileka emphefumulweni. So trainer lelo social worker qala ungathi ufuna ukuthi ngiyophila emoyeni kanti uyongidestroya even more. Nikeza ama contact details ama local NGOs are provide counseling or ama support groups uma ngabe khona. Ngiyazi ukuthi uhulumeni ke namhlanje noma ungathi ucela isipeleti uthi ama funds awekho, but it would be nice to have ama pamphlets ukuthi uma usukhulumile nomama bese umnikeza ipamphlets. So ke ngenxa ukuthi imali ke ayikho kahulumeni, into ongayenza phendula nje ikhalenda ubhale that information ninamathisele lapha. Kuyezwakala kusimple, ungakwenza kwenzeke lokho akufuni imali. So umandisa kuyena engilokhuzela la bengithi mina hayi khona odokotela la so lesi slide asikwazi ukubaxaka. So ke ijourney yami ke leyo advice yami ukuthi ningasilekelela kanjani singabazali babantwana bakhubazekile. And ngenxa yokusebenza yokuchazelwa kahle uDr Mbatha ngokukhubaza komntanami lokho kwangikhuthaza kwanginikeza amandla. Uyabona noma ngabe ngifunda information ngomntwana wami iyakwazi ukuthi yenze isense. Ibhayisikopho yenza njani manje? Okay. So siphinda ke sisebenza nama traditional leaders ngoba into okufuna siyi remind ukuthi parents of children with disabilities don't live in hospitals. They have to go back to their families and households and communities within which they live. So uma ufika lapha emakhaya kunama traditional leaders, so kusemqoka kuthini ukuthi sisebenzisane nayo ngoba bama custodian eculture. And ukhuluma iqiniso sisebenze nama traditional leaders from different districts and they are very supportive. Yezwakala iqiniso ufuna silikhuluma ukuthi mangabe sisaqala ukusebenzisana nabo they've got that attitude, you know, bebe na that attitude ukuthi no issue ye disability, issue ama nurse, issue odokotela, issue ama social worker, but uma ungabe usuhlezi nabo phansi yezwakala bayakwazi ukuthi be understand. And kwenye traditional court after sesenze workshops, because we are talking about ama rights abantu abakhubazekile, different types of disability nama causes akhona. And what was nice, basebenzisa izindlela, right? Ngoba phela iqiniso sifuna silivuma ukuthi in rural areas abantu abanye they cannot read and write. So what they've done is that after that workshop a member of a traditional council together ne group of young people, they benza a song about raising disability awareness. And what was nice is that that song bayayicula during isigodi meeting, and they'll ask the people, is this happening in your isigodi? And if people are saying yes, is that how can we change it so that ayenzeki futhi? Kuyezwakala. So basebenzisa ulwazi abalaziyo. And kwesinye isikhathi siyabacela benze inkondlo, then benze inkondlo, benze ama poems abo, bezokwazi ukuthi bahaye inkondlo during isigodi meeting. And they are very supportive. So ke uma ungabheka lesa sithombe salo wamntwana oshilo. Lo mntwana akashiswa ngamanzi, kuyezwakala. So umuntu, not that by accident. It was not an accident. So umuntu wayishisa lo mntwana, she was not burning a child, but she was burning the evil spirits akhona kumntwana, because umntwana ubenjani ubene autism. Ukuthi no, wena udinga ukuthi sishise le mimoya ekuwena. So yenze ocishe ngayishika indawo, kodwa yenzeke khona la kwaZulu Natal. Siphinde futhi senze advocacy kuma church leaders, ngoba ibona abashape ama values and beliefs about sin and punishment. Niyazi ukuthi uma ngabe singena sabantu abakhubazekile enkonzweni, umfundisi usuyeshumayela ethi nina nokukhanya kwezwe. But uma kangena umuntu okhubazekile ashintshe iverse ethi kuyobeka izandla kwabagulayo uqede basini. Ubani othe siyagula kwahleni bo. So but into ebemnandi ke la in this community, sisebenze futhi nama community service therapist. Oh, those women again bashayeleni izandla. Oh my goodness. Ingane humble. And it was so nice because bathema befika baba saba introduce enkosini, right? Ba introduce enkosini, then inkosi yabamukela, and if bemukelwe inkosi nomkhandlu, it means ama ancestors at that village abamukelile. And those women basebenza kamnandi kanjani. And because they introduce themselves there emkhandlwini. Uyazi mangabe I support group lapha na ihlangana ngo Thursday twice a month. Kodwa kusuka ama Thursday. And what is nice ukuthi induna himself will be the one ozohambe bavakashele omama. Ningakhohlwa ukuthi odokotela abancanyane bayeza, kuyezwakala. Ziyeza intombi zami, kuyezwakala. So asambeni ngoba uyabona manje uhulumeni uyanilekelela ukuthi ningaharishi imoto niyelena, but service isiza kuneni. Uyabona ukuthi bane support manje abazali. And uzophinda organize like some members of the traditional council or young people abangasebenzi ukuthi okay, mlekelele lona uhamba ngewheelchair, umntana wakho uhamba ngewheelchair, mphathisa isikhwama, ngiqhubise, kuyezwakala. And into yethu sonke siwumphakathi, kuyezwakala. And uyazi ukuthi office land yonankulu kwaZulu Natal ithi ingane yakho, ingane yami. But thina sabaza abantwana abakhubazekile, it's not like that. Ingane yakho, ingane yakho. Qiniso ukuthi sisho njani lokho? Bheka ke therapy department. How many of you ubona like black abantu abamnyama obaba bephelezela omama bakhona? Uthola umama uphethe wheelchair, uphethe umntwana, uphethe isikhwama. Kuyezwakala ushouta wo taxi driver lana bapho obaba balezi ingane. We've got no support. Kuyezwakala. And if we involve induna, they will help us. If we involve our traditional leader, they will help us. Ngoba egcina nje mhlawumbe ngizokhuluma nama traditional leaders, and one of the traditional council iyona eyenza disability awareness. Sengasasekho ngisho kuba bekho mina because ngabanikeza material ekhuluma disability ngesizulu, then it was useful to them ngoba bakwazi ukuthi ngingasasekho bekwazi ukuthi bezenzele bona disability awareness. Sengiqeda. So besisebenza ke la ogwini incane lento. Kodwa ke enye yama letters eyabhalwa womama bengane ekhubazekile lena. I hope ngizokwazi ukufunda ukuthi I'm writing this letter to thank you, to thank you about the ECD project. I know that one of the Ngiyakwazi ukufunda lana? Angiboni kuncane kakhulu. Kodwa nje iletha eyabhalwa abanye babazali, so omunye wabazali wayefuna ukubulala umntwana wakhe okhubazekile. And ngenxa yokuthi I was able ukuthola that session no Dr. Mbatha, sikwazile ukusave impilo zabantwana abakhubazekile. Sikwazile ukchange the negative attitude of the traditional leaders towards abantu abakhubazekile. And sikwazile ukuthi abazali babantwana abakhubazekile bengafihla abantwana babo beqala ama support groups. And kumnandi kakhulu ukusebenzisana nama community services, ama community service therapists esebenza nabo. Ekugcineni nangu Tebugo. My son, my future chef. So ziningi izinto ababezisho ama-specialist. So some said, angeke kwazi ukudlula grade 4. Some said he will make it to grade 12. So masikhuluma namhlanje uka grade 12, we head boy, and really thank you ku Dr. Mbata. I'm a therapist onke angilekelela, and it was nice ngoba ngangisebenza nama occupational therapist nami emsebenzini bakwazi ukuthi bangisupporte. And more than anything, thank you to Create ngoba bekuba nekhathi la ongelula khona, but banginikeza isikhathi sokuthi ngenze njani ngishaye umoya ngibuye senginomfutho angithi niyazi izulu sithini sithi ukuhlehla kwenqama kusho ukubaleka kodwa ukwenze njani ukuthatha amandla. So ke ukukhuthaza nje abanye abantu abasebenza nabazali babantwana abakhubazekile ukuthi if we work together nanga ama results akhona. Hayi ke intombi kaMdekelo njengetafula umakotambule emodolweni kwabo kwamangubane ngiyabonga.
I'm completely lost for words. I want to thank you from the bottom of my heart and from the audience for a truly phenomenal talk. I don't think anything could have spoken better about hearing our voice. So often we make plans in the big boardrooms, we come up with solutions, and we fail to hear what the issues are and what the priorities are. And we think that we're doing well. So I don't know if there's time. Would anyone like to reflect on how this has touched them or how it will change their practice?
Thank you so much, Sewongoma. I'm also very nervous myself, and I'm also very excited and very thankful for your presentation, ma'am. And you have truly done so for your son. And I believe your mom is something that your mother as well has done for you. The question that I have is about collaboration. I appreciate the point that you made about better collaboration with, among others, traditional leaders. In your presentation, you touched on a little bit about some interaction or maybe some points around traditional health practitioners or izangoma, whatever. But I would just like you to please comment on what you think the collaboration can be. Is there a need for collaboration between Western medicine, traditional health medicine, and how that collaboration can take place? Thanks.
The truth is, as Africans, there are things that we cannot really run away from. So in one community where I was working with the traditional leaders, so there were traditional leaders that were also traditional healers. So what was nice is that when I was doing a session with Yinama causes a CP, then there were these traditional healers there, and they said the way they have interpreted it is wrong. And the way, the methods that they have used to treat it was wrong. So what they did was actually to apologize to the mothers and to apologize to the ancestors for the way they treated those mothers and children with disabilities. So it is important that we work together so that we understand which bona ba lapha kanjani and nalaba base ntshonalanga balapha kanjani, and sibheke ukuthi kulokulapho kubekwe la phambili ikupho okusebenzayo, ikupho okufuna siku encourage, ikupho okufuna singakukhuthaza. Yes, kusemqoka ukuthi sisebenzisane.
There are so many sheep. Gosh. Warmly greetings. I'm Bonginkosi, 30 Clinical Associate student. I just want to actually stress a point. You have actually already mentioned this, but throughout my clinical exposure thus far, I've had via clinic and the district hospitals I've been to, I think the treatment we get from the healthcare workers, it hasn't like changed much. So I just want to mention that being a great healthcare worker isn't only about academic excellence. It's about how you treat people. It's about humanity. So we can do better. Like I wouldn't feel fine from the inside, from within, not mentioning this. Can we just improve the treatment? Thank you.
Ngicela ukubonga ma for sharing. One, where is Dr. Mbata? I think we need to find her. I think or him. Him. And I think we need him to share with other health practitioners how he handles cases like this. That's number one. Number two, to respond partly to the question asked about collaboration. I think we've got a platform now that has increased involvement yama different departments. So mhlambe as you go through ama districts nakhona la uGwini, look for a war room where there are different practitioners from different departments to share this. Ngoba sonke siyafana mase treata abantu. Si treata from our own story. Sibuka kanjani indaba. Lastly, I am a granny of a child like yours. So mangibuka uTebogo esenje, it gives me hope. But I still need to find the way you've managed uTebogo as opposed to how I manage my grandson. Thank you.
So, lunchtime.
Thank you so much. I think my big reflection is about, I'm from university. I think to reflect on the curriculum from the university, to say it's our curriculum addressing the needs of the community. Is our curriculum context relevant? Are we doing that we think it's important for our community? Are we hearing the voices of the community? So I think we need to re-engineer our curriculum so that we become context relevant.
My name is Nogwanda. I'm with the National Research Foundation at UKZN. I have a sister who was diagnosed with ADHD when she was in grade R, and she had the same experiences where she was told that she will not pass, and they really they couldn't help her. Basically, my mom, when she went to inquire about her progress at school, because she grew up normal, like you said with your son. She grew up normal, but then at school she couldn't pass. And I like how you said that people with disabilities don't live in hospitals. So I was wondering if you've had any collaborations with mainstream schools to help teachers understand children with ADHD, because I think that's an area where it's still lacking, where teachers don't, especially in early childhood development, where they don't really have an understanding of ADHD and any other spectrum disorders. Instead of sending children to special schools only, how can we integrate children with not mental, but like with ADHD in mainstream schools?
Ngiyabonga sis. A problem is now the problem that you have in South Africa. We've got abantu that have qualifications. You know, you've got your degrees, but you don't have a calling. You don't have a calling. Because honestly, if you have a calling, uzobona ukuthi umntwana unenkinga, and you will find ways of helping a child. So that is why, as much as I would really like to work with the teachers. You know, if they invite me in schools, I come and do the talk, and also invite them in our support group and say, you know, this is how we work together with my science schools. You know, I will share the information. I will also share I'm an occupational therapist, because one of the things that I'm autism is to break it activity. Ungati bala dweba yenza ukuthi but yenza step nge-step ungakusho konke kanye kanye. But noma ungakwenza lokho, even if you can give them that information, if there is no calling, the person is not going to do that.
Bongi, thank you very much. My name's Teresa. I'm also from the University of Cape Town. Your story makes me really reflect on that therapists across the board should really be embarrassed and should do a lot of soul searching in terms of why was the program for training community rehab workers allowed to be closed by Department of Health and by the professional boards, and why were we so powerless to actually let it happen. So there's a form of bullying that happens that we just all are part of actually, and that's what we have to own. And we talk about evidence-based practice and research, but how do you get your voices and your experience to actually be the one that counts? So I'm very grateful that this is being recorded, because I think it has to be shown not to parents and disabled people. It has to be shown to professionals and to those in power, to the Minister of Health, so that he starts supporting, and not just the Minister of Health, Kochte, the Minister in Transport, the Minister in Housing. I mean, what you've spoken about actually shows how this is the responsibility of every government and department, and how do we hold them accountable? How do we hold ourselves accountable? Your impact is more powerful than I think you can believe. And I think that people like you should be training future doctors, nurses, therapists. And become the chair of the boards, of the professional boards, so that they hear you.
Thank you. I want to make a personal statement. Bongi, you are a warrior. And I believe that more people were touched really deeply by what you shared with us. And I want to thank you for that. And yeah, I ask myself, through this worrying or your fighting, you brought peace and bring peace. Because you convert these very, very painful experiences into a positive message for others. And that is something special. It's not easy to do that. Thank you again. And my question to us is, do we see change? Because Bongi is not very young anymore. She's a mid-aged lady. And I ask myself, do we see changes? Time moves on, or are we still facing the very, very same, so painful experiences in our communities and healthcare systems? I don't know. Also, regional differences may apply here and there, but I still continue to hear similar comments, also where I work. And I'm ashamed that that we don't move on. Also in other cultures, also in Germany, where I come from, it's not all honey to be a person living with a disability, having a child who's maybe severely disabled, or yeah, even the unseen or invisible disabilities. We still are very stereotyped, and we have to move on. Let's think about it.
Thank you. Mama ngicela ukubonga nje kakhulu mhlawumbe ngomlayezo siphe wona. I'm trying by all means not to speak in English because already I'm sensing a little bit of a language barrier when it comes to our patients and how we deal with them on a daily basis. But you have taken us through an emotional roller coaster. And the way that you have done, it raises some questions within us as healthcare practitioners or workers. Now, of late, we've realized how much patients sue the state because of how we deal with them. Now, the reason why they sue us is not because of our clinical practice most of the times, but it's because of how we handle ourselves with them. Now, we need to come back and think about how do we think about how to better care for our people. A simple greeting when you meet somebody, a simple explanation of what they are going through, of which it's something foreign to them. And you need to make it as simple as possible for them to understand and be able to take care of themselves when you are not there in front of them. Amen. Now, the overall experience of our patients is that nurses and doctors and everybody else know it all. But the truth is that we can learn a lot from our people on how we can better deliver the services. These things that we do sitting in boardrooms and making decisions for our patients do not work. We need to listen and make decisions based on how our patients want to be served. Now, there are a lot of things that have been said, but when we're talking about disability as a point, I think to myself that perhaps maybe we need to gauge how we would be successful in providing universal health care to our people. And I mean, one of the ways, simple ways, is that a woman who's disabled, who lives in a rural area, who's not educated, receive the same kind of a care that the president would receive. Thank you.
Amen.
So, Musa again, and I feel like I'm being attacked for mentioning a boardroom this morning. And I want to invite you to the boardroom. And I want to see what happens when we do that, because maybe that's what we need to do things slightly differently. So at UKZN in the School of Nursing and Public Health, we are setting up a new institute which is designed to try and support the strengthening of primary health care and the work that we are doing with the department in terms of bringing healthcare into the homes of people. And we are, at the moment, going to call it the Institute of People-Centered Health. And Bernard is also here. He's also a member of the governing board, so I'm going to put him on the spot as well. I would like to invite you to advise us, but in so doing, be able to take you with us when we speak to the powers that be, when we speak to the people that think that they know what needs to be in the curriculum and not, when we speak to the people that decide on what should be funded and not. So that's the least that we can do in the boardroom.
Molweni, I know we're in Zululand, but I must speak isiXhosa. Bongi, thank you very much for your talk. I'm Ben Gaunt from Zitulele. I just wanted to add the angle of organizational culture, because it's the drum I beat. And I think that there are many different issues that you raised, and obviously the voice of people in the community is a big one. But I think that sometimes we also feel powerless as individual practitioners, and I wanted to highlight two things. The first was, who's Dr. Mbada, you was asked, or where is he now? And I was wondering to myself whether he even remembers. Now he might, because he might have a good memory, or he might remember because you sat there waiting until a Zulu-speaking doctor came to see you. So two things might have stood out for him. But he might not remember it at all. And many of our patients remember us, but for us it's just another day at work. And I think that's quite a profound realization when you have it for the first time as a healthcare worker, that you're changing someone's life but not even noticing it. And so part of it is building that narrative within healthcare, but also this idea that organizational culture can facilitate the right attitude. And we use a phrase at Zitulele, Njengo Sisi Wam, which means in Xhosa, as if she were my sister, and trying to promote this idea that that's how we should treat all of our patients. And it's a really useful marker when you're making technical decisions about what's the right type of treatment that you want to use, but it's a really useful marker for our humanity as well. We as leaders or colleagues or policymakers or whatever, we can't change every single person, certainly not overnight. It takes a long time to teach people some of these skills, but I think working at the different levels of influence that we have, and for those of us working on the ground as leaders or colleagues of other healthcare workers, and building organizational culture, and one that is focused on the patient, the person in front of you, or the person out there in the community, depending on whether you're public health orientated or not, is crucial. Thanks.
That was amazing. What a start this morning. Unbelievable.